Dr. Baliga here. This podcast belongs to a set of 10 podcasts on the topic of geriatrics. It's from an outstanding chapter on geriatrics in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It covers important topics including functional decline and frailty, cognitive impairment and dementia, evaluation of cognitively impaired elderly driver, depression in late life, hearing impairment, vision impairment, urinary incontinence, undernutrition, pharmacotherapeutic considerations in the elderly, including pharmacokinetics and pharmacodynamics, elder abuse and neglect, goals of care and advanced directives, and prognostication. After listening to these 10 podcasts, you should have a solid foundation in geriatrics and should help you provide better care to your senior citizen patients. This chapter is authored by Dr. Jeanette Ross, MD, who's professor at the University of Texas Health Science Center at San Antonio. She is the Associate Program Director for Geriatric Fellowship and Director of Didactic Activities for Palliative Care and Geriatric Fellows. Her academic interests include integrating geriatric palliative care content into educational programs at the undergraduate and the graduate medical educational levels. The senior author is Dr. Widera, MD, who is Professor of Clinical Medicine in the Division of Geriatrics at the University of California, San Francisco, UCSF. He is also the Associate Program Director for Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational interventions. Multiple choice question. A 76-year-old female is admitted to the hospital with dehydration and multiple small pressure ulcers on her sacrum and heels. She has lived at home alone since the death of her husband 1 year ago. She has no other family and no close friends. On exam, she is disheveled, wearing clothing that smells of urine. Her neurologic exam was normal, including a mini mental state exam score of 29. She is treated with intravenous fluids and wound care in the hospital, but is refusing skilled nursing home placement or home care services, stating that she can manage things by herself. What is the most likely cause of her presentation? A. Dementia. B. Self-neglect. C. Delirium. And D. Neglect. And the answer is B. Self-neglect. The patient's presentation is most consistent with self-neglect, which is characterized by the inability or refusal of an elder to meet his or her basic needs to an extent that it poses a threat to personal health and safety. The absence of a caregiver distinguishes self-neglect from neglect. Dementia is made less likely by the normal results of the mini mental score examination, although a normal score may still reflect a decrease from her baseline cognitive status. Delirium should also be strongly considered in this case, although cardinal features were lacking, including an acute change in mental status, inattention, disorganized thinking, and change in the level of consciousness. Elder abuse and neglect. Elder abuse can be defined as being any intentional or negligent act by an individual that causes harm or serious risk of harm to vulnerable adults. These actions may range from physical, sexual, financial, and emotional abuse to neglect. Both elder abuse and self-neglect are associated with increased morbidity and mortality. The perpetrator of elder abuse may be a person who is in a position of trust, such as a caregiver or a family member. However, abuse may also be self-inflicted, as in the case of self-neglect. Self-neglect is characterized by the inability or refusal of an elder to meet his or her basic needs to an extent that it poses a threat to personal health and safety. Self-neglect is the most common form of abuse reported to Adult Protective Services, yet it is estimated that only 1 in 14 cases are ever reported. There is no universally accepted screening test for elder abuse. Clinicians may want to interview patients separately from caregivers and ask some basic questions about potential abuse, including A. Has anybody hurt you? B. Are you afraid of anybody? C. Is there anyone taking or using your money without your permission? A complete history and physical examination, including a cognitive and nutrition assessment, should be performed when evaluating a person with suspected elder abuse. Laboratory and radiographic work-up can be guided by the history and physical exam findings. Healthcare providers have an ethical and often legal obligation to respond to suspected elder abuse. In almost every US state, physicians are required by law to report a suspicion of abuse or self-neglect. Failure to report is often considered a misdemeanor and can result in fine or jail time. More on whom to call and specifics for state-specific laws can be found at the National Center on Elder Abuse website. Once reported, Adult Protective Services is generally charged with investigating alleged mistreatment in community-dwelling older adults. In addition to promptly responding to and investigating a report, Adult Protective Services can provide a comprehensive assessment of the elder's needs and referrals to social support, medical, mental health, and legal services. In an outstanding article titled Elder Self-Neglect, How Can a Physician Help?, authored by Dr. Alexander K. Smith, MD, MPH, Dr. Bernard Lowe, MD, and Dr. Louise Aronson, MD, on December 26, 2013, they discuss approaches that may help physicians to find a combination of creativity and pragmatism that may help older adults who are self-neglecting. They go on to say there is no single answer for this condition. This podcast is derived from an outstanding chapter on geriatrics in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It's authored by Dr. Jeanette Ross, MD, professor at the University of Texas Health Science Center at San Antonio. She is also the Associate Program Director for Geriatric Fellowship. Her academic interests include integrating geriatric palliative care content into educational programs at the undergraduate and graduate medical education levels. Her main interests include advanced communication skills, goals of care, pain management, and management of falls in the elderly. Her clinical activities are based in the South Texas VA healthcare system, where she is a staff physician within the Geriatrics department and extended care services, and she is affiliated with the Geriatric Research, Education, and Clinical Center. She works in the Geriatrics and Palliative Care Consultation Service and the Geriatrics Clinic. Dr. Eric Widera, MD, is Professor of Clinical Medicine in the Division of Geriatrics at UCSF, that is University of California, San Francisco. He's also the Associate Program Director for Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational innovations. Dr. Widera accomplishes this through various leadership roles, including Director of the Hospice and Palliative Care Service at San Francisco VA Medical Center, and he's the Program Director for the Geriatric Fellowship at UCSF. He has been the recipient of numerous grants and awards, including a Geriatric Academic Center Award at the Hastings Center Kenneth Dixon Physician Award and the Hartford Foundation as a Center of Excellence Faculty Scholar Award.